Clinical Systems Intelligence Training, Module 3, Clinical Audit. I'm a primary care rep. Didn't realise how complicated it is for practices to build searches and how easy it is to get it wrong. It became apparent that a barrier to clinicians treating patients aligned to product licensing and NICE and local guidelines is identifying the patients in the first place. I now understand that this needs to be quick and easy, and we were able to implement a national strategy to enable clinicians to focus on specific cohorts of patients. So what are you going to learn about in this module then? Module 3, Clinical Audit. So we're going to look at the definition of clinical audit, LHE and national level audit, the role of audit in primary care, building a search, and supporting primary care. Key objectives are for you to know the difference between audit and a search and understand the barriers in primary care to creating specific searches. This is a definition of clinical audit, and it's a cyclical process. So clinical audit is a way to find out if healthcare is being provided in line with standards and lets care providers and patients know where their service is doing well and where there could be improvements. The aim is to allow quality improvement to take place where it will be most helpful and will improve outcomes for patients. Clinical audits can look at care nationwide, national clinical audits, and local clinical audits can also be performed in trusts, hospitals or GP practices, anywhere healthcare is provided. So to start with, you identify your audit topic, you then set the standard, you then collect your data, analyse the data and implement change. And you then need to run that again so you can look at the changes that have been made and have they improved standards. So clinical audits can be run at practice level, so searches and queries are used to identify specific cohorts of patients, and they can be exported and imported from practice to practice. They can be run local health economy and national level, so LHEs may run audits remotely, so they can have sharing agreements set up across their practices which enable them to remotely access and run data. There are built-in searches already in all of the systems for QoF, for direct enhanced services and local enhanced services. And there are also many national disease areas that are covered by audit, so diabetes, COPD, heart failure, etc., through Healthcare Improvement Partnership. But whether it's at national or local level, all these audits are based on common data, and some examples of this common data would be medication, SNOMED codes for problems and or symptoms, test results, demographic information, registration information, appointment information, or any combination of those things. The National Clinical Audit and Patient Outcomes Programme is managed by the Healthcare Quality Improvement Partnership and contains more than 30 audits, most of which involve services in England and Wales, and some also include services from Scotland and Northern Ireland. And there's a list here of some of the examples. So you've got a National Diabetes Audit, National Asthma and COPD Audit, and the Sentinel Stroke National Audit Programme, which I suspect some of you have already heard of some of these. So CQC and clinical audit. We've often been approached by practices who want a quick audit doing because they've got a CQC inspection coming up. So we thought we'd spend a bit of time looking at what the CQC actually say about audit and does it meet any of their requirements. The CQC look at different lines of inquiry. So under key line of inquiry E2, the question is, how are people's care and treatment outcomes monitored and how do they compare with other similar sources? And practices should routinely review the effectiveness and appropriateness of the care provided in order to provide effective, safe care. So clinical audit is obviously an excellent source of evidence that quality improvement activity is routinely taking place within a practice, and practices should be able to demonstrate that they consider the quality of care that they provide, review the care they provide in relation to best practice guidance, make changes where necessary or appropriate in order to improve, and then revisit the question to see whether the changes made have resulted in an improvement. So clinical audit does meet some CQC requirements and it provides evidence. In a similar vein, GPs obviously have to be revalidated, and we looked again at what the GMC require for doctors around the topic of clinical audit. So for the purposes of revalidation, the GMC require that all doctors demonstrate that they regularly participate in activities that review and evaluate the quality of their work. So clinical audit in itself is not a revalidation requirement, but it can form part of quality improvement activities or projects. The RCGP recognises that there are many different types of quality improvement activity in addition to clinical audit that are equally acceptable. They should show thought about quality of care provided, review of care in context of current good practice guidance. They should celebrate when no changes are needed, make changes where necessary, and they should be revisited. So they should revisit the question to see if the changes made have made an improvement. So it's a lot around evaluation and review. Okay, please pause the presentation here and answer questions 1 and 2 for this module in your workbook. Start again when you're ready. Got an example audit report to show you now. So a set of searches have been set up on the clinical system which provide lists of information, lists of patient numbers basically, and this is an example of how you can use those numbers to create a meaningful report. So this is from our SPAF and case finding service. So the first page just confirms who the practice is. This is obviously a dummy one. So we've got the prevalence of atrial fibrillation and the value of a QOF point. So this is all around how many patients they have with atrial fibrillation in comparison to the national average. Then we've got case finding in the current year, so how many new patients have been diagnosed, and then out of that number how many are on the correct treatment, how many are on no treatment, how many have been exception coded. This is outcome of case finding, so those newly diagnosed patients, have they had a manual pulse check to diagnose them? Have they had a lead 1 ECG or other? If they've had a lead 1 ECG, what was the outcome? If they've had a manual pulse check completed, was that regular or irregular? This is risk stratification, so for those patients with atrial fibrillation, what's their CHA2DS2-VASc score? Which group do they fall into? Are they on treatment or not? Is there any other work to be done for these patients? This is the therapy breakdown. So again, for that group of AF patients, if they're at high risk, are they on antiplatelet? Are they on a DOAC? Are they on a VKA? Exception coded or no therapy? You can see lots of different analysis. So this is just from lists of patients numbers that we've found within the audit, and then that's been pulled out and analysed by using these reports. This is to look at the DOAC dosing for those patients. So you can see listed down the side of the graph here, you've got all the different search numbers. So if you wanted to go and find these 2 patients here, for example, you can just go into your system and look at search 6.7 and you'd find them all here. The second graph here is showing patients with missing data. So to get the correct dosage, we need to have the serum creatinine, the has bled, and the weight creatinine clearance. So if we don't have that data, we can't be sure that the dosing is correct for these patients. And then after all the analysis, these are the lists of patients for actioning. So within the clinical system, they would go straight to this search and they would find these 2 patients, and there's a considered action here. Again, all the different groups of patients, and the practice can access their report and find these patients to review them and monitor them. Okay, so that's the baseline audit, and obviously to be an audit rather than just a set of searches, this has to be redone to show the completion and show where changes have happened. So we can see from this page the detection rate was at 115%, it's gone up to 127, so they can show that there's been an increase there. Patients protected, i.e. on the right therapy, it actually has gone down slightly, but that's because they've identified more patients. Then how many patients have had their warfarin reviewed and got time in therapeutic range readings, INR readings recorded, etc. And then how many patients have had their weight, serum creatinine and creatinine clearance recorded. So that's showing the changes that have been made. So we can see here the register from initial to re-audit has gone up. You can see here the difference in the numbers. Again, so all these graphs are showing the changes that have happened, how many patients have got exception coding, how many have had an INR analysis, how many have had an annual review, etc. Same with the breakdown of the therapy and the DOAC dosing. So that shows that's an audit rather than a search, because it's been redone and the report has picked up the changes that have been made. So clinical audit or a search. So a clinical audit is a cyclical process, as we've just discovered. To be successful, it must be actioned and repeated, and it can be used for benchmarking and quality improvement, showing changes in results over time. A search can be one-off to meet a specific need. For example, a medication has been withdrawn, therefore you need to know the list of patients who have been taking it. Patient contact required, so a clinician has cancelled a clinic or the change of clinician and you need to contact the patients. They can be regular and repeated, so blood tests to be done every month, or patients with missing annual reviews to be run annually. All of the QOF searches are built into the systems. So for example, patients with missing blood tests for diabetes or blood pressure not to target, etc. Those are already built into the system. So those are searches rather than audits. So here we're going to create a search. We've called it diabetic patients on insulin and based it on all currently registered regular patients. We're going to add some rules to the search. So create a new rule, clinical codes, add a new list of codes, find the code for diabetes, and select all of those. So any type of diabetes. Add another rule. This is going to be codes again. New code list. This time we're looking for HbA1c. So choose the code and confirm. And this one we want to make sure we only pick up the latest one. So using the date, choose the latest one and then check that the value is more than 59. Okay, to confirm that. We're going to add another rule. So this is the code again, clinical code for cholesterol. Again, choose the date and the latest one. And the value is greater than 5. Okay, we can see we're looking for the rules here, so they must have these rules to appear in the search. And we're going to add another rule for the medication. And we're going to look for all types of insulin, so we can use the drug dictionary here. Open up the different chapters. And we're going to include all types of insulin. Then we want to check that the medication is still current, hasn't been put into past drugs or cancelled. So So we ran that search and we found no patients. So let's have a look and edit that and see why that might be. So it turns out we've chosen that the patient must have an HbA1c over 59 and a cholesterol greater than 5. So I've changed that to read either or. So it's now going to look for patients with either of those. And that's brought me 48. So it just goes to show how easy it is to get these rules wrong and get the wrong groups of patients. So by clicking on the population included, we can go into their medical records if we wanted to do a review, and we can create an automatic report as well, which is quite handy. And once that's run, you can view the results, and that will show you all the patients. So you'll see what type of diabetes they've got, how long they've been diagnosed, and what their latest readings were, and what their current therapy is. Okay. Okay, let's have a look at some case studies with this one. Okay, so this case study is about clinical system searches. So the situation was that updated national guidance, which was published, was available to practices, and it was very favourable for this brand X. The guidance suggested a very specific cohort of patients, which meant quite complicated searches. And as I'm sure you can tell from the example that we just looked at, it's very easy to make mistakes, and the practices found it difficult to create the searches to identify these patients. It doesn't mean they couldn't do it, it just meant it was time consuming and it was quite difficult. So the solution was that Oberoi created a set of ready-made searches to be imported into the clinical system based on an agreed set of criteria. So that included disease codes, it included medication, excluding patients who had been on previous medication, including patients that had had specific test results, etc. So it's very important that these criteria are agreed at the beginning of these kind of projects to make sure that they find the right patients for review. And the results of the practices actually employing this solution and using these importable searches was that there was an increase in uptake of brand X where these searches were deployed. So this is a case study of a clinical audit tool to support atrial fibrillation. So this was a collaboration with Kent Surrey Sussex Academic Health Science Network, and we looked at implementing the SPAF, which is a stroke prevention and atrial fibrillation service, across 10 East Kent GP practices. And this was to be facilitated by clinical pharmacists across all those practices. The aim was to improve the detection of AF and optimise the use of anticoagulation through the implementation of a package of tools and resources, as AF-related strokes are severe and are associated with significant mortality and morbidity. So the audit was one of several tools that were provided. So the total package included Lead 1 ECG devices, virtual anticoagulation clinics to support the practices, the Oberoi SPAF and case finding service, and then CVD mentorship and education programs, and an online platform with CVD shared learning and resources. So the data and the audit tool was key to this. It gave them a systematic approach integrated with the GP clinical system, so they didn't need to add on any additional software. It gave them real-time analysis of patients who have AF and are at risk of stroke based on certain criteria which are already within the patient record. To support perfecting anticoagulation, it identified whether incorrect doses of DOACs were being given, enabling clinicians to correct those doses to improve efficiency and reduce potential side effects for patients. For those on warfarin, it identified which patients have time in therapeutic range recorded in the system, and where they did, those with a value of less than 65%, linking into the NICE guidelines. And then it provided monthly dynamic reporting through the SPAF e-portal to show the impact being made on detect, protect and perfect against the baseline. So the reports were available at practice level, at PCN level and at CCG level. So this is some impact data from the case study that we did. So across those 10 practices, over a 5-month period, you can see that 129 new AF patients were detected, and there's some calculations there that 5.2 strokes were saved in 1 year and £214,000 of health and social care costs. So that's around detecting new patients. Then for protection, this is the whether they're being treated with anticoagulant or not. Again, this time we had 7 practices which returned data across that same 5-month period, and 113 new AF patients were anticoagulated, saving 4.5 strokes in a year and 187,000 potential costs. And then for the perfect data, so this is looking at whether the patients are on the correct dose. We've got 7 practices that gave us data. At baseline, 90% of patients prescribed with warfarin didn't have time in therapeutic range, and at the re-audit that had dropped to 83%. And in the same way, at baseline, 51% of patients being prescribed DOAC had elements of data missing, so they didn't have a weight or a serum creatinine in their data, and that had dropped to 44%. So you can see that scaled up, that would make quite a big difference, quite an impact in this AF area. Okay, thank you for completing Module 3, Clinical Audit. Please make use of your workbook to record your notes and answers, as these will form part of the live webinar.